will discuss the lectures from the tutorial. For the OSPE discussion, you need to remember some important instructions. During discussion, you will find the clinical history is quite extensive, but in the exam, the history will be very short, very small, just 1 or 2 sentences. So the main purpose of OSPE examination is you should interpret the gross, microscopic, or clinical images, or the combination of these images, right? And you might have either one or two sub questions. So you need to answer those questions. And then please don't use any abbreviation in the exam. Write full, complete name. So we'll start with the case discussion. So let's begin with the. I have already uploaded this PPT on the Moodle. Yes, can you see my screen?
Yes, doctor.
Yes, doctor.
Okay, so we begin with case number 1. So, 43-year-old previously healthy woman presented with headache and fever for the past 2 weeks. She had a history of severe respiratory tract infection 2 weeks back. On physical examination, her temperature is 38.5 degrees Celsius. There is right hemiparesis. CT scan of the head shows a sharply demarcated 3 centimeter ring enhancing lesion in the right frontal region. While undergoing treatment, the patient went into respiratory failure because of unknown cause and died. Autopsy was carried out as per the hospital protocol. The slice of brain and microscopic image is provided for interpretation. Right. Now, if you look at the history, you will find that middle-aged female patient, she presented with fever, headache, and neurological deficit in the form of right hemiparesis. And a very important history was elicited that this patient had a past severe respiratory tract infection, right? And if you look at the features, the clinical features, you will find that there are 3 important clinical manifestations: headache, fever, and neurological deficit. So these 3 important features, they are called as the triad, right? So the 3 features means the triad. So these are the triad of brain abscess, right? If a patient is presenting with brain abscess, then there is high possibility the patient will present with headache, fever, and focal neurological deficit. So these are called as triad of brain abscess. Then we confirm our suspicion by doing the CT scan or the MRI examination depending upon the availability, and then we find that there is a 3 centimeter ring enhancing lesion. So again, this indicates that the patient is having a brain abscess. Then unfortunately, this patient died before the treatment, and we have this slice of brain. Right. So if you look at the now, if you look at this slice of brain, gross picture, you will find there are 1 and 2 prominent lesions. So these are well demarcated lesions, and if you pay attention, at the border you will find there is a brown ring. There is a brown ring around these lesions, and if you look carefully, you will find the central area is little bit depressed. In this area, you will find a slight depression. So what does this mean? What does it indicate? This depression indicate that there is central necrosis, right? So because of the necrosis, that area has got depressed. See, the brain is already soft, and if there is necrosis which is more softer than the surrounding bone, so it causes a slight depression, right? And we know in the brain, the necrosis which is seen is called as liquefactive necrosis, right? And why it is called liquefactive? Because it is more like it has a jelly-like appearance, right? Like more like a liquid. Exactly, it is not liquid, but it has appearance like a gel. So it is called as liquefactive necrosis, right? So from the gross, again, we can confirm our suspicion that these are brain abscess. Then next, we send this, we take a sample and we send it for histopathological examination. And then we process it and we see under microscope. So now in this image, we see basically three important zones. So this is the first zone and this is another zone. Okay. And there is third zone, which is beyond this in this area, which is not totally visible in this image. So basically there are three zones, three areas. So in the central zone, in this area, right? In this area, you see liquefactive necrosis, right? So in the image, you see blue dots, right? You see blue dots, and in the background, you see some pink material. So this blue dots and this pink material, these are nothing but the nuclear and cytoplasmic debris of neurons, glial cells, and even the neutrophils, the dead and viable neutrophils. And sometimes even you may find bacterial colonies, right? If you stain it with gram stain, you will find bacterial colonies. So this is the area of liquefactive necrosis. And then next, this is the second zone, this one. And here you will see blood vessels, round structures. So these are blood vessels which are filled with red dots. So these red dots are RBCs. So this is neovascularization, zone of neovascularization. And there is a third zone which is not clearly visible in this area. That is the zone of gliosis. That is the zone of gliosis. So these are the three microscopic areas or three microscopic zones which are seen in a patient of brain abscess, right? And this confirms that this lesion is a brain abscess. So these are the possible questions. What is the most likely diagnosis? So the diagnosis here will be multiple brain abscess because we have more than one, right? So you should write multiple brain abscess. And what are the three important microscopic features? So at least you should write two important microscopic features. Number one, liquefactive necrosis. Number two, neovascularization. And number three, gliosis. So these are the three important microscopic features. You write any two, preferably try to write liquefactive necrosis and neovascularization. Then next, case number 2. So am I clear with case number 1? Any doubt, any query?
Clear, doctor.
All right. Now, case number 2. A 50-year-old man was brought dead in the casualty department of a hospital. Autopsy was carried out to know the cause of death. His medical records showed a history of atrial fibrillation followed by sudden right-sided body weakness. The slice of brain is provided for interpretation. So again, a 50-year-old man, patient presented with, the patient died, the patient was brought dead in the casualty department, right? And by looking at the case records of the patient, it was found that this patient had a history of atrial fibrillation, which was followed by the neurological deficit in the form of right-sided body weakness. So now, unfortunately, this patient died, and we have this slice of brain for interpretation, right? So now in this image, look at this area. Okay. So in this area, you will find there are brown dots, right? So these are nothing but the areas of petechial hemorrhages, right? These are petechial hemorrhages, and this area has become infarcted, right? So this is an area of infarct, and this area of infarct has some brownish discoloration or petechial hemorrhages. So this is called as red infarct or hemorrhagic infarct. So this patient died because of hemorrhagic infarct or red infarct. Now, how to correlate with the history? So if you look at the history, there is a history of atrial fibrillation. So now how can you correlate the history of atrial fibrillation with the brain infarct? So if you remember, atrial fibrillation is one of the important predisposing factor for development of thrombosis in the heart. And that thrombus is called as neural thrombus because it develops in the cavity of the heart, right? So because of atrial fibrillation, in atrial fibrillation, the atria, they will not pump like this normally. They will just fibrillate, right? They will just fibrillate. So because of this atrial fibrillation, there will be stasis of blood. And this stasis of blood, it is one of the workout triad. If you remember CVS block, in that you have already studied Workhouse triad. So Workhouse triad means three factors which are responsible for development of thrombosis or thrombus. So atrial fibrillation leads to stasis of blood. Stasis of blood will lead to thrombus formation, and this thrombus get dislodged, it become embolus, and from the left side of the heart it enters aorta, and from the aorta it reaches to the brain, and it blocks one of the blood vessel in the brain, which leads to infarct, and this infarct is called as red infarct or hemorrhagic infarct, and the reason is embolism. So what is the most likely diagnosis in this case? It is red infarct or hemorrhagic infarct. So either you write red infarct or hemorrhagic infarct. And what is the most likely cause for this condition? So here you should mention embolism, right? Don't write atrial fibrillation. Atrial fibrillation is already given there in the history. But atrial fibrillation will lead to formation of thrombus, and this thrombus will become embolus, and this embolus will cause obstruction of the cerebral blood vessel, right? So you should write embolism. Then mention the most common artery which is affected in this condition. So if you remember, the most important artery which is involved, which is affected, is the middle cerebral artery. So you should write full complete name. Don't write MCA, right? Middle cerebral artery. And why middle cerebral artery is frequently involved? Because if you look at the origin of the middle cerebral artery from the internal carotid artery, you will find that it is more in continuity with the internal carotid artery. So if there is some embolus, or if there is some material which is moving in the vessel, in the internal carotid artery, there is high possibility it will enter middle cerebral artery rather than anterior and posterior, which are placed more acutely with the internal carotid artery. Did you understand this point? Because middle cerebral artery is it is more in continuity with the internal carotid artery. So there is high chances, high possibility that the embolus will obstruct, it will block middle cerebral artery. This is the reason. So am I clear with this?
Yes, Doctor. Clear.
Okay.
Yes,
now,
doctor.
all right. Now case number 3. An 80-year-old woman fell down the stairs. About 36 hours later, she developed headache and confusion and is taken to the emergency department. On physical examination, she is drowsy and has a scalp contusion on the occiput. CT scan of the head shows a collection of blood in the subdural space. So from the history, you get an idea that elderly female patient, she had a history of trauma, and because of which she developed collection of blood in the subdural space. So basically, she developed subdural hematoma or subdural hemorrhage. So what is the most likely cause of hemorrhage in this case? So the most likely cause is, if you look carefully, you will find these are called as bridging veins. So rupture of bridging veins, right? So the likely cause of hemorrhage in this case is rupture of bridging veins. So you should write, just don't write bridging veins, right? You should write rupture of bridging veins. And if you remember, at the time of lecture, we discussed that bridging veins are the veins which run over the convexity of the brain. So in very old age, what happens? There is atrophy of the brain. Brain shrinks. And because of this shrinkage, the veins which are running over the convexity, they become tense. They become tense. And even with the slightest amount of trauma, this tense vein, they may easily rupture. And also, because of the old age, the veins, they also become more fragile. Right. Now, case number 4. A 42-year-old drowsy woman presented to the emergency department with complaint of the worst headache of her life. Few hours later, she developed nausea, vomiting, and weakness of the right side of the body. There is no history of head trauma. Interpret the gross images and answer the questions. So, a very characteristic history: young, middle-aged female patient presenting with worst headache of her life. Right. So, if you remember, we have studied a condition in which it leads to excruciating severe headache, followed by the neurological deficit. And another important history is there is no history of head trauma, right? This is another important history. No history of head trauma. It means the bleeding or the hemorrhage or the pathology is spontaneous. It is non-traumatic. Right. So this is the gross image. So now, if you look carefully in this area, and this black colored material, this is the blood. This is hemorrhage. These are blood clots. Okay, which are present at the base of the brain. And what is the, so this is called as subarachnoid hemorrhage, right? And if you remember, we have studied, we have discussed that subarachnoid hemorrhage is usually present at the base of the brain. So basically we are looking at the base of the brain, and here you can clearly see the circle of Willis. This is circle of Willis, and most probably this is the ruptured aneurysm from which the patient developed this hemorrhage or the subarachnoid hemorrhage. So what is the most likely diagnosis? The most likely diagnosis here is subarachnoid hemorrhage. And what is the most common cause of this condition? The most common cause is rupture of saccular or berry aneurysm. So again, write full complete sentence. Rupture of saccular or berry aneurysm. So this is a gross image which shows an aneurysm, right? So this is a saccular or berry aneurysm. So write the name of this cerebral aneurysm. So the name is saccular or berry aneurysm. Mention the most common site. The most common site is junction of anterior cerebral artery and anterior communicating artery. Write full complete sentence what I just mentioned. Junction of anterior cerebral artery and anterior communicating artery. Don't write any abbreviation. Write full complete answer and full complete name of the vessels. Okay. So these are the possible questions on this case. Right. Now case number 5. A 50-year-old chain smoker with long-standing uncontrolled hypertension and diabetes mellitus experienced acute onset of weakness and numbness on the left side of his body and an inability to walk. He mentions history of intermittent bouts of severe headache. His blood pressure upon arrival to emergency center was 192 by 104 mm of Hg. Suddenly he went into cardiac arrest and expired. Autopsy was carried out. A slice of brain is provided for interpretation. Right. Now, if you look at the history, 58-year-old chain smoker, right? So what is a chain smoker? It's a heavy smoker, you can say, right? One who smokes maybe 1 packet or 2 packets of cigarette every day. And this patient has a long-standing history of uncontrolled. Again, pay attention to the words uncontrolled. The hypertension and the diabetes mellitus, they are not in control. And this patient develops acute onset of weakness. So this patient has a history of smoking and important history of uncontrolled hypertension and diabetes mellitus. So these are all important predisposing factors. And this patient experienced neurological deficit, sudden neurological deficit, and he also has a history of bouts of severe headache. And in the emergency department, look at his blood pressure. It's extremely high. So this is called as hypertensive emergency, right? Very high blood pressure. Now again, unfortunately, this hemorrhage, right? Large area of hemorrhage. So now you need to correlate the history with this slice of brain, right? So here you see a large blood clot or a hematoma or hemorrhage. So this is intracerebral or intraparenchymal hemorrhage. The hemorrhage or the blood is present within the substance of the brain. So this is called as intracerebral or intraparenchymal hemorrhage. So this is the diagnosis. And what is the possible cause of this condition? So the possible cause, don't write hypertension and diabetes mellitus. What does hypertension and diabetes mellitus leads to in this patient? They will cause rupture of small intraparenchymal blood vessels, right? So the possible cause is rupture of small intraparenchymal blood vessel. So that was all about case number 5. Now case number 6, an 86-year-old man, resident of a nursing home, is found wandering the streets looking for his way home. The patient's family describes deteriorating cognitive function that has been worsening progressively over the last several years. He does not have a history of head trauma or cardiovascular disease. In addition to the disorientation, the patient has demonstrated significant language and emotional impairment. So the history is very straightforward, very clear that this patient is suffering from Alzheimer disease. So the patient has dementia, loss of memory, and also there is progressively decline in cognitive function. Then there is a progressive decline in higher intellectual functions and also emotional disturbances. And we know the important pathological features, lesions which are present in the brain of this patient. So here we see 3 important features. So A is called as, this lesion is called as neuritic plaque. Neuritic plaque. PLAQUE, plaque. Neuritic plaque. And B, in this image, if you look carefully, you see some entangled fibers. So these are called as neurofibrillary tangles. Neurofibrillary tangles. And in C, you see blood vessels which are thick, thickening of cerebral blood vessels. And this thickening is because of deposition of amyloid. So this lesion, this pathology is called as cerebral amyloid angiopathy. Cerebral amyloid angiopathy. So these are the 3 lesions: neuritic plaque, neurofibrillary tangles, and cerebral amyloid angiopathy. So what is the most likely diagnosis in this case? Alzheimer disease. Just don't write Alzheimer. Alzheimer is the name of the person, right? So write Alzheimer disease. Identify the distinct pathological findings observed in brain sections A, B, and C. So for A, you should write neuritic plaque. For B, write neurofibrillary tangles. And for C, write cerebral amyloid angiopathy. Now case number 7. Physical examination of a 62-year-old man revealed fascinating gait, stoop posture, bradykinesia, muscle rigidity, pill rolling tremors, and mask-like facial expression. So what is the most likely diagnosis? So if you look at the symptoms, so they form part of a spectrum. They form part of a diagnosis which is called as Parkinsonism, right? Parkinsonism. And if you remember at the time of discussion, we have discussed what is Parkinsonism and what is Parkinson disease. So now if you look at the history, your diagnosis is Parkinsonism. But now pay attention what I'm saying. Now, when you see this image, your diagnosis should change, right? So in this image, you see a very important structure which is present inside the cytoplasm of the neuron. So this is called as Lewy body, Lewy, Lewy body. And now your diagnosis will change to Parkinson disease. So the most likely diagnosis here is Parkinson disease. So identify the pathological finding. The pathological finding is Lewy body. Lewy is the name of the scientist who first described this. Lewy, Lewy body. And mention the name of the abnormal protein. Now pay attention to both the questions, first and second, right? So the pathological finding is Lewy body. And the name of the abnormal protein is alpha-synuclein. Is this clear? Mention the 2 most common site. So number 1 is substantia nigra and number 2 is locus coeruleus. So these are the 2 most important common sites, substantia nigra and locus coeruleus. All right. Now case number 8. A 40-year-old woman has been in good health until recently when she developed recurrent headaches. A CT scan reveals a 2 centimeter extra axial dural based frontal mass. Right. So in this image, you see a large, solid, smooth tumor which is attached to the base of the dura. So we say extra axial. What is the meaning of extra axial? Extra axial means any lesion inside the cranium which is arising outside the brain. It should be inside the cranium and outside the brain. So when we say outside the brain and inside the cranium, it means something which is attached to the meninges. Is this clear? So this is the meaning of extra axial. So this is a large solid tumor which is attached to the dura. So we say dural based tumor. and this tumor is causing depression of the underlying brain. So the patient will have neurological deficit because of this compression. And we take section and see under microscope, we see two important microscopic features. So here you see whorls of meningothelial cells, right? So this is called as in concentric circles, right? Whorls of meningothelial cells. And in B, these are cymoma bodies, right? So whorls of meningothelial cells A and B is cymoma bodies. So you should write full complete answer. So what is the likely diagnosis? Your answer should be meningioma. The diagnosis is meningioma. And two important microscopic features, A is whorls of meningothelial cells and B is cymoma bodies. Right. Now case number 9. A 9-year-old girl is evaluated for headaches and ataxia over the last month. A CT scan revealed a midline partially cystic cerebellar mass. The tumor is removed surgically and microscopic examination shows elongated bipolar astrocytes with fibrillary processes and Rosenthal fibers. So a very characteristic, very straightforward history. A child presenting with cerebellar mass, headache and ataxia, right? And so we have a tumor here which is arising in the cerebellum, and we know in children the most common site is the posterior fossa cerebellum, and we have these microscopic features, right? So these are all malignant astrocytes with hair-like processes, microcyst and Rosenthal fibers. So the most likely diagnosis here is pilocytic astrocytoma. So again, you should write full complete name. And again, I'm repeating, I have mentioned this at the time of lecture as well. Don't write pilocystic. Even after me telling that don't write pilocystic, still the students, they write pilocystic. And it's a wrong name. It will totally change the meaning of the tumor, right? So pilocytic, don't add extra S from your side, right? So it is pilocytic, Pilocytic. And mention the pathological grade. Pathological grade is grade 1. Now, case number 10. A 20-year-old male presented with the following clinical manifestation. There is a history of similar clinical manifestations in the family, or there is a family history. So these are the clinical manifestations. So in this image, you see, look at the torso of the patient. It is studded with hundreds of tumors. So these are all neurofibromas. And in the eye, you see these brownish round bodies. So these are called as Lish nodules. These are Lish nodules. And this one is hyperpigmented macule, also called as cafe au lait macule. So we discuss this in detail at the time of lecture. What is cafe au lait macule? So this constellation of symptoms is present in a condition which is called as neurofibromatosis type 1. So the diagnosis in this patient is neurofibromatosis type 1. Again, don't write abbreviation, write full complete name, neurofibromatosis type 1. Now, case number 11, a 5-year-old boy presented with headache and ataxia. Interpret the following images and write the diagnosis. So here you have the MRI image showing a well circumscribed tumor arising in the cerebellum. Gross image showing a tumor with a central area of necrosis. And when we take a section and see under microscope, we get a very typical picture which is called as small round blue cell histology, small round blue cell morphology. So this tumor belongs to the family of small round blue cell tumor. So what is the diagnosis in this case? So the diagnosis is medulloblastoma. The diagnosis is medulloblastoma. Now case number 12. A 15-year-old boy is diagnosed as a case of ependymoma. Write the name of the characteristic rosettes, right? So here you already know the diagnosis. That is ependymoma. And what are the important microscopic features or the rosettes which are seen here? So in image A, this is called as true rosette. This is called as true rosette. And B, this is the blood vessel. So this is called as perivascular rosette. Or you write pseudo rosette. So this is true rosette. This is pseudo rosette. A is true rosette. and B is perivascular rosette or pseudo rosette. Now, case number 13. A 65-year-old male is diagnosed as a case of glioblastoma. Write the name of the microscopic features. Right. So in image A, look at this area. So this pinkish material is necrosis. And in B, look at this structure. This is vascular proliferation. These are all endothelial cells, right? So there is proliferation of endothelial cells. So necrosis in image A, necrosis, and image B, vascular proliferation. These are the two important distinguishing microscopic features of glioblastoma. Is this clear? So if you find these two microscopic features, it means it is definitely glioblastoma and nothing else. Any query, any doubt? Am I clear with all the cases?
Thank you,
Clear,
doctor.
doctor.
Yes, everything is good.
Okay. So now what I will do, now we'll take some break and I have